I have now the privilege to introduce Dr. James Misak and Singh. Jim is the Chief Medical Officer for the Institute of Hope out of the MetroHealth System. Mimi is the Kowal Professor of Geriatric Health Education at Case Western Reserve School of Medicine and the Director of Health Professions Education Evaluation and Research, the Research Advanced Fellowship at the VA. We touched a little bit in Rita's talk about how Better Health Partnership has managed to subdivide the work into our leadership teams. We have an adult leadership team, a children's health leadership team, all of which have subcommittees. We've addressed our infant and maternal health needs through the first year Cleveland activities. And we have what's called a Health Metrics Advisory Committee, and you're going to be hearing some from some of the work that's been done there that has branched out into addressing the effects of climate change on health. And we'll be hearing from them in a minute. But Dr. Misak and Singh are going to talk about the adult leadership team's efforts in addressing racial disparities. And I think the one thing that's important to add before we move on to this talk is just an awareness for the audience that all of the participants in these leadership teams, the subcommittees putting these programs together, are volunteers. They have joined forces with us through Better Health Partnership to try to improve the health of the community on their own time with the support of their organizations. And I am just eternally grateful for all the work that's been done. Jim and Mimi, I turn it over to you.
Thank you, and good morning, everyone. Kudos to the Better Health team for a terrific collaborative up to this point. It's been a very rich learning experience, and thank you so much for putting this together. And also, Dr. Ford, congratulations. The cream always rises to the top, and we will miss you, but I'm sure you're on to bigger and better things at the Cleveland Clinic. If I could have the next slide. Dr. Boland reviewed some of this information already. Through the efforts of Better Health Partnership and the collaboration amongst the healthcare providers in Northeast Ohio, we have managed to reduce the gaps in certain aspects of chronic disease care over the course of the last several years. This slide shows how gaps, racial disparities and gaps in diabetes care, as measured by the 4 items in the box to the right of the slide, have been reduced but not eliminated over the course of the time Better Health Partnership has been collecting data. So while a rising tide lifts all boats, some of us are still in leaky rubber rafts and other of us are in yachts. If I can have the next slide, please. Again, Dr. Boland reviewed this while because through the implementation of best practices, blood pressure control improved across multiple racial, ethnic, income parameters. Disparities still exist as they're shown here. If you look in the middle upper slide by race ethnicity in 2019, African Americans still have much poorer blood pressure control as a whole than white or Latinx communities. If I can have the next slide. Same story with diabetes. Disparities still persist by race and ethnicity in terms of diabetes control. We're looking here at a measure of poor diabetes control, so lower is better. And as you can see, non-Hispanic whites are doing the best. The Hispanic community is doing the worst. And interestingly enough, these numbers haven't changed a lot over time for much of anybody. I think my own feeling is that the COVID pandemic has definitely impacted our ability to impact these numbers. If I can have the next slide, please. So Better Health Partnership pulled together an adult leadership team to try and address the problem of persistent racial, ethnic, and income disparities in adult chronic disease care and outcomes. Diabetes and hypertension being the 2 for which we have the most data, but not the only 2 by any means. So unlike what you've heard previously, we are taking much more of a QI approach to this by teeing up a smart aim and then trying to move that QI approach upstream. So our smart aim is to reduce racial and ethnic disparities by some percent across all PCPs and Better Health Partnerships Collaborative by a certain date. And X and Y have yet to be determined. This is a work in progress, and we certainly would appreciate your input in terms of what X and Y should be. If I can have the next slide, please. This is a very busy slide, but the way we decided to approach achieving this SMART aim was to develop a driver diagram. And those of you who are familiar with driver diagrams know that you go from your aim to primary drivers to secondary drivers to change ideas as you move left to right in the diagram. And then hopefully by implementing the change ideas to the right, you then go the reverse direction, to influence the secondary drivers, which in turn influence the primary drivers, which in turn influence your SMART aim. The primary drivers that we determined might be most impactful in this are listed in brown. They are the quality of the clinical care we deliver, the social determinants of health, the accountabilities of our health systems, and policy. And then we broke each of these down into secondary drivers, which you can see in the middle. And then in turn, tried to tease out change ideas that would influence the secondary drivers, which in turn would influence the primary drivers, which in turn would influence the SMART aim. So if I can have the next slide, please. Once we determined our change ideas, we asked everybody in the adult leadership team to rank these change ideas on a 2x2 matrix, assessing what they believed to be their feasibility and their impact. And obviously what you want to do is work on change ideas in the upper right-hand quadrant of that 2x2 matrix, the things that are both have the most feasibility and hopefully will make the most impact. And so we took all the change ideas and ranked them on this 2x2 matrix. And the next slide shows what we distilled as the 3 change ideas, priorities that we have chosen to work on in the adult leadership team. And they are community engagement, social care referrals, and integrated behavioral health. And what we are trying to do now that we've identified these 3 core change ideas is to identify what are best practices in each of these areas, what metrics can we agree to measure our progress on these, and how do we share learning and learning collaboratives such as this. And hopefully if we can identify some replicable best practices to which we can attach measurable metrics and share the learning across the health systems, hopefully we'll make some impact in reducing racial and ethnic disparities in adult chronic disease measures. So that's the plan we are following. We are still early in this process. And with the next slide, I'm going to turn it over to my colleague, Dr. Singh, to talk more about where we are now.
Sure. Thank you, Dr. Misak. So I want to, again, thank you for framing the work that we're doing. And as everybody has been hearing all morning, there is a lot of complexities to what we've taken on as a charge. And I hope some of the things that I'll be presenting in the next couple of slides will reflect that complexity and the very thoughtful work that our adult leadership team has been doing. I will present kind of what we're doing currently, as well as kind of our next steps or how the future looks for us. So as Dr. Misak mentioned, we've identified 3 priority areas given the drivers and the thoughtful process that our team has gone through. And now we're asking teams on the adult leadership team to share the best practices in these 3 areas. And the sharing is around these important questions. What are you doing as a system in your particular priority area that you selected as a potential best practice? How are you doing it, which is of course the most important? What's working well? And of course, with all this work, we know the challenges and opportunities that come up. So share those. And ultimately getting back to this larger question of what are some of the strategies that will help us achieve this aim that we've taken on, which is to reduce disparities in chronic disease. Next slide, please. So this is a table that essentially that's showing how our different team members are sharing the community engagement, integrated behavioral health, and social referrals. The highlighted areas are teams that have already presented, and we'll be presenting some of the lessons learned from them. And the other teams are going to be presenting over the next couple of months. We meet monthly, and what I think this does show is that we have incredible expertise in all three of these priority areas. I do also want to mention that a lot of our team members have done excellent work in all three of these priority areas, and we kind of put them in a sticky spot by asking them to pick one based on maturity of projects or maturity of program, based on measurement and the effectiveness. So we did kind of pin them down and say, well, pick one. But as you will hear, and as you've been hearing this morning, many of them can share best practices in all three areas. And we're hoping to learn from them. Next slide, please. So here's the real, what are we learning? So we kind of presented the logistics, but we're learning a lot. And a lot of this is coming up in the conversations that we've had all morning during this collaborative. And as we've heard from our team members, there are four main elements that are coming up as themes in the category of community engagement. So what are those themes? Level of integration considerations. So how are the community stakeholders incorporated into the healthcare organization? Are they employed? Are they external partners? Do they sit on the board? Are patient stakeholders part of the conversation? Similarly, decision-making considerations. How is the community feedback and decision-making incorporated into the healthcare organization? And this has really been an eye-opening experience because we've seen that there's a continuum, that community feedback can be simple as surveys, as we've talked about early on, to actually having team members part of a regular meeting. And as mentioned, whether they're kind of high up or at the ground level, how is that interface occurring? Next slide, please. The other pieces that we've learned, and one that's come up multiple times during the morning, is trust building. And we've shared through our project, through the programs, that establishing trusted relationships is really important. We have, whether communities have an influential liaison with the healthcare organization. A critical lesson that we're learning is we all too often in healthcare kind of meet people with, where do you need to go? Here are the gaps. But really we should be asking the question, where are you? Where is the community and where they are? And not necessarily going in with our agenda and where they need to be. And then more importantly, healthcare organizations, are they a part of the respect, and can they effectively deliver? And this really gets back to the last point, which is, does the community and the healthcare organization actually share mission and goals? And this is a critical question that's coming up in all of the presentations so far, that if the community partners do not see the healthcare organization on the same page when it comes to value systems, that really does create a barrier to sort of some of the work that's going to be needed in this area, i.e. in reducing racial disparities. So if the community partners see the healthcare organization as an other and just kind of taking up zip code space, if you will, and not necessarily aligning along the lines of value systems, the conversations are going to be much more stickier and a lot more uphill battle. I think a simple statement that that has come up multiple times when we've talked about this is that if patients and families in the community if patients and families do not care what you know, if they know you do not care. And that is something that we've noticed as we've been talking to our partners. Next slide, please. So this is a busy slide, but we want to just show that we are going to continue this conversation. So we shared our community engagement conversations, but similarly, we're going to have similar conversations around social referrals, as well as integrated behavioral health. And as you can see, we're planning on doing the same thing, sharing best practices, what has worked, what are some of the ways we're operationalizing or measuring, what kind of data will we need? So this gets back to what Better Health has done so well, which is transparency of data, collection, and taking a very methodical QI approach, so that when we do disseminate this, people can actually not only contextualize it to their systems, but really get the best out of the practices and the strategies. Next slide, please. So ultimately, this question has come up this morning: what does success look like? And this is kind of our aspirational goal, that if we do as a team, as an adult leadership team, share these best practices and approach these strategies, that we will ultimately get to an upstream integration and get to our ultimate goal of reducing health disparities. And so what that would look like is patients coming into our healthcare organization, well-connected, coordinated care, really meeting both their social and their behavioral needs, that best practices in chronic disease would not just be limited to what we think of as the traditional way, which is just hemoglobin A1Cs and blood pressure control, but really taking into consideration the social components in those conversations. And ultimately that this will show up in our quality health outcomes. So I think here I would just say that as a team, we are exploring, we've learned a lot. I think this morning's conversation has really led me to think that that we're validated and reinforced in sort of approaching things with more of a coordination around social and behavioral needs, as well as building trust. And we hope to continue that conversation. And next time at a next Learning Collaborative, present some more specific data around these 3 priority areas. I think that is the last slide. And if there are any questions.
Thank you so much, Jim and Mimi. Yes, we do have a few minutes for questions. If anybody would care to put one in the chat, we'd be delighted to see if we can answer them. I am really impressed and moved by the idea that you expressed, Mimi, about asking the fundamental question: do we share the same goals? If we just assume that is a yes, then I can't see how we're ever going to have success. Not that the goals necessarily are different, but we have to understand those. As such, is the leadership team incorporating? I know this is a work in progress, but have you designed this to accept that there may be different solutions for different organizations in different communities?
Definitely. I think, again, we're exploring, and what we've learned just from the presentation so far is that context matters. And so I think some of these strategies will not be, and we've talked about this in our team conversations, is that some of these strategies might work in one community, but may not, or some tweaking will be required based on the context. And I think that's one thing I have learned a lot from working with this group, is we recognize that that need for that flexibility, because unlike traditional best practices, if you will, which we tend to present within the healthcare system, one high blood pressure technique might be pretty standard across multiple clinics. I think this work really speaks to the variation in the work. And I really am impressed with how our team has really handled the fact that, well, maybe this will work in this context, but we might have to tweak it based on, another neighborhood and another zip code. So I think that is built into the exploration. I don't know if Jim has any comments on that.
Yeah, I think even though this slide says best practices, what we're really looking for are better practices that are replicable but flexible, given the nature of what it is we're trying to address.
Thank you for that. There's a question in the chat: who was involved in the determining of what change drivers are most feasible and what would have the highest impact, and how were these individuals recruited? Should we tell them about the press gang where we hit people over the head?
And the large bribes that we offered. Yeah, let's talk about that.
No, I said you're volunteers. Come on.
Jim, did you want to?
I think, well, actually, I would ask Rita maybe to weigh in on this as to how the constituent organizations were asked to participate.
Well, thanks, Jim. Thanks, Jim and Mimi, both of you. So our adult health leadership team starts to get formed by those who are submitting data to us and who have worked with us over the years, know our model well, and want to make that difference really in the community and the lives of so many people living in Northeast Ohio. So through that process, I think the question being asked in the chat is really, who weighed in on those change ideas? It was everybody. And when we didn't get answers by email, we called people and we chased people until we had everybody's input on this, so that we were able to, in fact, determine what the group felt. Most importantly, what can they work on collectively that they can't just accomplish in their silo alone? I think that's a really important point to make. really staying focused on the collective impact of the group and what would carry us forward. And so it was really important that everybody had a voice in that decision and that prioritization process. I hope I answered that person's question.
And I think it's really clear to all of us, this is an approach from the health system out. So at best, it's complementary to everything else we've been talking about this morning. In no way is this sufficient on its own.
A comment from Pamela Murphy, need more African-American providers. I would just say you're absolutely correct, and that's something we strive for on our committees at the staff level of Better Health Partnership, certainly on our board level, and in all the work that we do. And I appreciate the reminder. Question from or comment from Amy Scheidler, funding discrepancies between health systems and CBOs create a gap between social determinants of health screening and intervention. Are there plans to identify other funding sources to enhance gap closure of social needs?
Yes. I can start. Yes, I think the astounding answer is yes. And I think some of the work that we're doing, and again, as Jim mentioned, this is part of it. This, in many ways, we're kind of bringing the healthcare organizations, if you will, to kind of hand holding them through this process, if you will. And by saying that, I mean, a lot of the discussions we have in our healthcare organization is around, we need data, we need collection, how does this operationalize? And I think some of the work the adult leadership team is doing is that we recognize a lot of this, the critical nature of SDH on these health outcomes, but translating it and kind of getting it to so we can get funding and things requires a little bit along data collection and data assessment. And that's the piece that we hope to bridge. So of course, we would love to, to get more funding, and especially when we can get some of these gaps better identified. So I think that's the ultimate goal, if not one of the main goals. Yes. I don't know.
Great.
Jim. Oh, sorry.
Well, let me just move to our last question quickly. Asking about the role of the Unitas platform in the integration framework, and I suspect that with the matrix that you showed, Mimi, that's going to be a significant part of that.
Yes, Jim might want to comment on that.
Yeah. Yes. As of now, MetroHealth and the Cleveland Clinic are part of the Unite Ohio network, which links healthcare systems and community-based organizations via an electronic resource referral platform called Unitas into a network called Unite Ohio. We currently have over 140 community-based organizations as part of the Unite Ohio network. And so I think it is a really powerful tool for allowing communication, not just between healthcare providers and community-based organizations, but among community-based organizations to meet the health-related social needs of individuals. Now, again, communication is only a piece of the puzzle. How the CBOs get paid for the work they do is an example of what economists call the wrong pocket problem, right? That the work is being done here, but the benefits are accruing there. And there's a ton of work being done nationwide right now to try and solve this problem. But it's a sticky wicket, and Unite Ohio, I think, opens up some possibilities to solve that problem, but in and of itself does not.
Terrific. Heartfelt thanks to both of you for your leadership in this important work. You've herded cats, you've untangled balls of string. You've given direction to something that is huge and deeply important. Thank you very much.